Okay, welcome to Spine Conference. Today's discussion is going to be anterior cervical non-union repair. Just want to tell everyone I'm recording this conference and posting it on YouTube, so please make all comments rated E for everyone and HIPAA compliant. So I always like to show cases, and these are real cases of mine. It's a 48-year-old woman whose chief complaint in the office was neck pain and right scapular burning, and that radiated to her right posterior elbow, right triceps area. She presented in August 2018, which is 2 months ago. Her symptoms started in 2017, 1 year prior, and she was 2 years post-op at that time. She is status post C4, C7 ACDF in July 2015, so 3 years ago. I always ask if they had dysphagia, dysphonia, any problems post-operatively. She had none, just to make sure she had no intraoperative esophageal injury or recurrent laryngeal nerve injury. Everybody knows why you have to know if the recurrent laryngeal nerve was injured from the first surgery. Who can tell me why it's a big deal? Yeah, and then knock off the other side, and then what happens? Yeah, no voice. So she had no problems. She's a relatively healthy person, L5S1 discectomy in 2010, left carpal tunnel release, sinus surgery, cholecystectomy. She's a right-hand dominant nurse for the VA. She's married, 2 grown children, non-smoker. So a pretty healthy person, 5'7", 185 pounds. These are her x-rays 3 months post-op, which she saved and gave to me. So my question is to the audience, anybody can answer. Do you think the interbody grafts are a fine size, reasonable size, good size? And do you think all of the screws are locked? This is 3 months post-op. Do you think the locking mechanism is working? Anybody have any opinions? I can just keep talking unless somebody wants to. Any opinions? Okay, so the bottom screw, the bottom C7 screw, is that, you guys are convinced that's locked? It's obviously it's a loaded question. Okay, maybe not. And the grafts, what do you think of the grafts? They're good size, too big, too small? I thought they're a bit big, but. So these are 3. Now this is, in retrospect, this is the plate that's in her neck. I removed it. I did not know that she had a Synthes Vectra anterior cervical plate. I thought she had the second generation Synthes plate, which locks with an inner screw inside of the screw. This one locks with these little slots that come out. So the screw goes in and the slot goes over the screw and keeps the screw from backing out. Now, looking at this mechanism, these slots are about 3 millimeters deep to the very front of the plate. Now, knowing the locking mechanism now, what do you guys think? Do you think those screws are locked now? Knowing the locking mechanism now of this particular plate.
I think the whole profile of the screw head is visible outside the plate. If the locking mechanism is recessed 3 millimeters into the plate, then those screws likely aren't being captured by the locking mechanism.
Yeah, I don't think so. Right? I mean, I'm not sure myself, but I learned from these cases from looking at them closely. So I was thinking, yeah, maybe they weren't locked. So what is the optimal graft height for ACDFs? Is it 2 millimeters more than the disc height? When you do the case, you can see how you view it. You have to remove both the anterior and posterior ossiphytes really to do a good job to both the anterior ossify to see, the posterior ossify to see into the spinal canal. Should the graft fit perfectly? Should you put a larger graft so you cannot remove it intra-op? Like, these are the questions. And then, I mean, for people who distract, if you distract with a Casper pin, look at the posterior facets. Should you distract a lot to spread the facet posteriorly and then put as large of a graft as you can? Is that how you should do it? I mean, how do you put in your Casper pins? You have to see over your pins, so how do you angle your pins is the question. And do you have to remove a lot of bone from the vertebral bodies to see into the spinal canal? Does anybody have, the other thing is the optimal graft should be somewhere between 7 and 10 millimeters because most people are similar size. So does anybody have any opinions about what's the optimal graft? I'll tell you what I do is is I remove the anterior and posterior osteophytes. I distract with the Casper pins, not excessively, and then I loosen the Casper pins to see how much movement there is. Sometimes there's no motion at all. Sometimes in a young person there's a lot of motion. I place a graft, and then I remove the distraction from the Casper pins, and I pull in the graft and see how tight it is. And that's kind of how I size my grafts. I usually use an 8 graft because that's Cal Ripken's number, so I use the number 8. So does anybody have any other opinions? How do you put, Paul, what size do you use?
It depends on the patient. I think you definitely want to oversize a little bit, because I think even if you don't get a complete decompression by distracting that segment, you open the frame indirectly. So I think a little distraction is okay. You want to try to restore some lordosis. And sometimes inevitably to do that, you have to over distract. And I think the important point about the over distraction is patients typically have pain that's kind of across their shoulders in a cake-like fashion for about 2 or 3 weeks if you do over-distract.
Over-distracted patients, yeah, because the capsules stretch and that hurts.
Right, and it all goes away when you tell them all that you're going to have this potentially. And I think the tendency is clearly with cervical spine is for you to be, if you're going to cheat more on the over-distraction, I think, to be successful.
If you under-distract, then you get a non-union. That's the thought. Or you don't spread the foramen.
You may not
open the foramen.
Decompress the foramen if you under-distract. So.
Yeah, but if you're sure you decompress the foramen from a decompression, from removing the facet, you should be okay with the under.
You should, but again, if there's a little bit of subsidence of the graft, it might get a little, you have to always anticipate that, especially with the allograft bones and depending on the osteopenia of the patient, just sometimes get some subsidence of the grafts as well. So it's kind of a decision made at the time of surgery.
Okay. So, oh, this is bad. 1 second, guys.
And have a new compression across that graft. If you can't get any of it in, then it's going to be too tight. And
the trial?
Yeah. So put the trial in. If you can get the trial in about 1/3 of the way, you will probably find that's just the correct amount of snugness. So it's not over distracted, it's not loose.
Okay. All right, so this is 2 years. This is 2 years post-op when she started having the symptoms. Any changes? Does anybody have any comments or opinions about the lateral x-ray? You think the screws are backing out a little more? She started having right scapular pain. Okay, we don't have to have any opinions. Okay, so now it's 3 years post-op on the right. And so on the very left, 3 months post-op. In the middle, 2 years post-op. On the right, 3 years post-op. And you can see the screws definitely have migrated anteriorly some, worsened. You see that the graft now is invaginating into the C7 body more. And then the other interesting thing, look at the arrows. At 3 months post-op, you can see a lucent line behind the graft, can't you? And you see a lucent line all across the graft and posterior to the graft. At 2 years post-op, there's bridging bone behind that area, and there's no bone along the graft. So,
what is that sign called, Jess? If you see it in term, especially it was termed mostly when you're doing ALIF, ancient lumbar spine fusion, with the old cages.
The picture frame?
No, picture frame. What does that represent? Picture frame.
Sentinel.
Sorry?
The sentinel sign.
Sentinel sign, exactly. And you see that bone that's going from vertebra to vertebra, that was called the sentinel sign, and it was kind of first described when we're doing anterior lumbar spine fusions. You're talking about Paget's disease with the picture frame.
Okay, so let's say you're doing a spine operation, a fusion, and the patient comes back with pain. Why do patients get pain after a successful fusion? So, and anybody can interrupt me, or add something. It could be a non-union, it could be adjacent segment degeneration of a facet stenosis, it could be instability above or below the fusion. It could be that the pain generator was never included in the fusion in the first place, like wrong surgery. And it could be that the pain generator was never in the spine in the first place. The wrong surgery again. So the question I have now, I'm going to ask Dr. Lemma, because every time he talks, I learn something. I have to keep close attention. The question I have now is, can you observe an ACDF non-union with no symptoms with an anteriorly migrated screw? Can it fuse in place with no sequelae? Can you give it more time? Like, what are your thoughts?
I'm less worried about the anterior migration as I am with that corticocancellous graft that's going to start to lever on that screw.
So it's migrating down. It's sort of creeping down, isn't it? Because you have a lever arm of fusion, and you're worried because it keeps creeping into the body and it's levering and it's eroding into the C7 body.
Right. So if the interbody graft bone interface looked fine with good graft incorporation, and I had that screw that had backed out a couple of millimeters, I might watch that. But this is happening in slow motion. You're seeing this graft beginning to subside into the superior end plate, through the superior end plate of C7. It's going to start to push on that distal screw more. It's going to cause it to crack out, and eventually that plate is going to start to kick off.
Okay.
Let me ask, so that's the patient was completely asymptomatic and comes in for another reason, or would you do something, or would you watch it still? 2 years out,
Completely asymptomatic.
no neck pain, just get an x-ray, you see that, you know there's non-union, you know that they have little migration of that screw, would you?
The graft subsiding.
Let's say this case is asymptomatic, no symptoms whatsoever.
That's a tough conversation to have with the patient. I would probably give them the option of revising it or having them come back in 3 months, check it again, 6 months, check it again.
How many months out is this person?
3 years. So Paul, this WebEx thing is killing me. Okay. Okay, so let's go over. There's a loaded question I want you guys to know. So this is a slice through C7. You can see just anterior to the vertebral body, prevertebral fascia, and then the esophagus. It's right there, and then the trachea. So a typical approach is transverse through the platysma. You go lateral to the straps. Everybody knows this. Medial to the carotid sheath, and then into the vertebral body. And the esophagus is right in front of the vertebral body. And then when you retract against the esophagus. So this is an article I sent everyone, Journal of Neurosurgery Spine 2016 from Emory. It's a meta-analysis of esophageal perforation. And I'm sure everybody read the whole thing. And my fear in these cases is mediastinitis. What if the screw erodes into the esophagus, which is right there, and causes mediastinitis, which is a serious problem. So in this review, 153 patients, 65 articles, 19% of the injuries were intra-op. And the interval between the perforation, like when the perforation happened, and then when you start treating is a predictor for survival. So in other words, if you have a perforation and you don't treat it immediately, there's a much higher chance the patient will not survive this problem. So the average time to diagnosis was 2 years, which is kind of shocking. And the median time was 44 days, about a month and a half. But to me, this article changes the way I'm practicing because I don't follow the patients up after a year or two. But I think maybe I should, maybe if I'm not 100% absolutely sure it's fused. Because some people erode into their esophagus a year or two out. The mortality rate was 4% for these patients. The time to oral intake was median 15 days, average 30 days. So these people don't eat for a very long time. And the typical treatment was a sternocleidomastoid flap. So this is just showing you how many people were early and how many people delayed. Most of the people that have esophageal tears were over a month out. They were diagnosed over a month out, which usually people are doing fine by that point. So the typical way to diagnose it is esophagram. Hey, Dr. Samir, can you tell us what we're seeing here? Hold on. That's the second one. It's kind of quick. So the first one is a normal patient. The second one has an esophageal tear. That's the second one. Let's do it again. It's a short video. So this is the first patient, normal. orthoscopic. You do that as a modified direct swallow. You see extravasation of the dye in this person. This person had a tear. So I just wanted to show you guys the typical way to make this diagnosis is barium swallow. And you see extravasation of the dye. Okay. And this is just a case of, so the next article was just a case of a late screw migration after screw plating. This was Spine Journal 2002, C4, C7, ACDF. The screw was unlocked post-op. You can see here post-op, the screw was unlocked on post-op day 3. Patient was asymptomatic and they decided to watch it. Now 13 months post-op, the screw is definitely out, and patient is asymptomatic. This was in Italy. And they just decided just to watch it. Patient has no symptoms whatsoever. Why should we go into the front of his neck? And then 19 months post-op, screw's gone. Where's the screw? And they got worried. At this point, they finally started getting a little worried. They did a CAT scan of the whole body. There's no screw in the whole body. It's gone. So they did an esophagus. They put a scope into esophagus to see esophagus is fine. So what happened?
It eroded into the esophagus and then went through
Asymptomatically eroded into the esophagus, past it, esophagus healed. So, okay, here's another case.
That's a lesson for waiting. You gotta wait these things out.
Interestingly, that's what the patient surgeon said. The patient said sometimes you just pass these things without a problem. But the patient was very disconcerted with that. She was really scared. Okay, so here's another case. 65-year-old woman had dysphagia 3 years out, so she's symptomatic. And sorry about the quality of the x-ray, but the screw is definitely out, and it's anterior. It's 3 years post-op. So this was not in an orthopedic or spine journal. This was in an otolaryngology journal. They put a scope in, and they see a screw. So this screw had to be removed. So the question is, again, can you watch these screws? What does everyone think? Me personally, I'm very nervous watching a screw. I'd rather just take it out because the mortality incidence is 4%. It's really high. And then you don't eat for a month. It's a serious problem. And I mean, watching something like that, me personally as a treating physician, makes me very nervous. Okay.
His comments were that Claire had reviewed a medical legal case where a patient had esophageal perforation and probably happened at the time of surgery and was recognized afterwards. And you don't really get mediastinitis from cervical esophageal tears that's been lower down that you actually, because you get, it's kept localized. What you do get is localized swelling and swallowing difficulty, and you may get an infection localized. But I think we've all seen when you go back in and you redo surgery to remove a plate, you get a very thick fibrous layer over the hardware. And I think if you have a little bit of a protruding screw and it's stable, I think it's safe to watch those because you know that there is a protective layer that develops after surgery. But
look at this, Paul. I mean, I used to think, listen,
I would say if the screw is out completely.
I used to think that too. But look at this. Over 30 days, look how many people tore their esophagus.
Yeah, but weren't those intraoperative?
No. The intraops were the first bar graft. So the 13 is intraop and 1.
Did you mention earlier that a lot of these were intraoperative? You mentioned earlier some a lot of these were intraoperative.
Let me tell you what this graph shows. These are all esophageal tears, okay, in the meta-analysis. The 13 and the 1 are intraops. Everything else is post-op. Everything else is hardware failure and chronic erosion of hardware. So the whole point of this meta-analysis is this happens way out post-op from non-unions.
Yeah, it's a meta-analysis, and I kind of wonder, again, from personal experience, we've all seen some screws that are protruding a little bit, and I can't recall any in 30 years of experience that I actually seen a screw erode through an esophagus where it was protruding 4 millimeters. Okay, I haven't personally seen that. So again, I kind of with the meta-analysis, it's hard to really get, you know.
So you think it's exceedingly? You think it's exceedingly rare? Is your point?
I mean, what about the other guys, Justin? And what do you think, Medstar? What are your thoughts on your experience from seeing perforations from hardware like screw and pit? What do you think?
Let me show so Justin knows what we're talking about.
One of the things that meta-analysis did not show is this failed hardware, but we don't know the extent of the failed hardware.
Watching that.
What it doesn't tell us is what's the incidence of esophageal chronic or subacute erosion of the esophagus with screw protrusion of a couple of millimeters. We don't have that information. So is erosion the screw loose and floating, you know, in the throat? Is it a plate kicked off? Is it a very prominent plate? Is it an old generation plate that used to be really thick? So it's hard to extrapolate that data for this particular case. In a case like this that likely represents a pseudoarthrosis with periscapular pain that you might be inclined to revise anyway, I would go on. If the same patient came in asymptomatic without that graft subsidence, I would probably want to.
But certainly you can get a barium swallow and you can see if there is an indication of the esophagus at that point. I think you're more justified to say, look, there is definitely impingement of your esophagus and building. But if you go in and you do a barium swallow and there's no impingement of the esophagus at that point because of the scar tissue layer,
you think you'd be able to see it?
It's safer to watch it.
It's pretty fast.
Your tear is anterior. Your tear, in this case, the tear is anterior. It's not. So is that related to your hardware, or is that just an intraoperative tear?
That was an intraoperative tear.
Okay.
Okay. So all right, let's keep moving. So this is a CT. This is a CT post-op 2017, where she started having symptoms. And look at the arrows. The first top arrow is bridging bone, Paul's-Dorian sentinel sign, C4, C5. C5, C6, we don't have that sign. At C6, C7, we don't have that sign, right? And now let's do the CT in 2018. Now both of those are fused. C4, C5 is fused, C5, C6 is fused, C6, C7 has a black line. So my question to you all is, where did that bone come from behind the vertebral body? There's no graft there. Well, where did that bone come from? What happened? Why is there like 12 millimeters of bone? I have my own theory. Does anybody have a theory? Where did the bone come from? How does that grow? We didn't put a graft there, and yet there's a huge amount of bone back there. Does anybody have a theory? Somebody's got to have a theory. I have my own theory. Anybody guess?
What do you think, Andrew?
Where did the bone come from? You see what I'm talking about right behind the bone? There's a huge amount of bone there. Nobody put bone back there.
I think with the stability conferred by the plate in the body, over time it sort of filled it in as a healing response because it's not moving.
So the bones grew out, the cells grew out of the vertebral bodies and met each other? No, you're smart. I have my opinion is from hematoma. So after these cases, it fills up with hematoma, and it behaves like a fracture, just like a big wad of callus in a kid femur fracture. That's my theory. What do you think, Paul? You always are my counter argument. You think it's a bunch of BS?
Again, it's certainly an observation we see that if you truly have a solid fusion, the entire.
Where's the bone come from? My question: where's the bone come from?
It must be something to do with Wolff's law and the forces.
So it grew out of the body?
Well, there's a couple things here, Stu. Number one is, do you have a pre-op CT scan? Because at least the back of 2, 3, 4, 5, 6, that looks like a typical osteophyte. That probably wasn't for second.
I got you. I got you on this. Look at 5-6, the second arrow. And now look at 5-6 now.
Right, so that's healing behind the graft. We see that all the time.
Yeah, my question is, where did it come from?
What are you talking about?
Where'd the cells?
Yellow arrow?
What?
Behind the yellow arrow?
Where? I'm just curious. Where did the bone come from? Where did the bone that fused? Where did this bone come from?
It heals across the disc space.
So the bones grow it grows from the bodies.
Absolutely. If you don't cover the end plate with graft, bone heals across the end plate.
Slowly.
Yeah. Oh, for sure. You see it happening posteriorly. You see it happen anteriorly as well. I thought you were talking about the blue arrow. Why there's still osteoarthritis.
That's the non-union.
Right. No, the upper levels.
Yeah, you can call that a posterior sentinel sign or whatever you want to call it. But we saw that in disc replacements. If you didn't cover the end plate, you have tremendous cancellous surface area, and bone will heal across. You'll also get bone healing outside of the end plate. You can get HO surrounding that area, either in cervical or lumbar. I like to see that, actually. If you put B&P, the problem with that is that you can actually get bone that grows out into the canal. So you can get extra bone or ossification that puts your longitudinal ligament that can then cause stenosis after you've done the fusion. But that, if you go back, you can actually see the hallmark is that it scallops in. Like behind that yellow arrow, the bone actually scallops in a little bit at the level of the disc space. You're more concerned if it actually goes out. Yeah, we see that. You see that experimentally also in goats. If you do an ACDF in a goat and you use a small graft, they put bone around the graft, whatever cancellous bone surface is not healed.
Okay, let's keep moving. So these are the coronal section on the right. You can see the lucent line underneath the body all the way across. The axial cuts are not so helpful. So this is just fusion versus, it's a race like we talk about. On the left, that car is the bone fusing. On the right, that car is the implant failing. So it's a race between the implant failing and the bone fusing. And if the bone doesn't fuse in time, the implant usually fails. I'll put cars because I know Paul's Dorian likes cars. So I did get an MRI just to rule out stenosis above or below or any neurological compression. And I didn't see any. And the axial cut at C6, C7, the level non-union showed no stenosis. So if there's no stenosis of the frame in any level, where is the scapular pain, posterior triceps pain coming from? Can somebody tell me? If there's no stenosis in the cervical spine on an MRI, where is this patient's right scapular pain, right posterior triceps pain coming from? I have my own theory, but who wants to say? Dr. Mohit, what do you think? If there's no stenosis in the cervical spine, where is this pain coming from?
Maybe the pain is not related to the neck, and maybe it's scapular dyskinesis. It may be something else other than the neck.
Scapula itself?
Scapula itself.
How about non-union? You think could it be the non-union pain giving her pain in the scapula? Maybe. The other thing is, what if there's a micromotion there, and although there's no stenosis, the micromotion is causing an inflammatory response on the nerve root at the level of the non-union. Can that give you radiculitis, you think, pain? You think that's possible? I mean, I think so. What does anybody else think?
Everybody's referred pain, facet pain. The movement of the facets.
The facet is moving abnormally?
We get referred pain all the time that radiates to the knee. I mean, this is radiating to the elbow, but not into the hand.
That's a normal facet back there, though. The facet's not.
Well, but it's got micro motion at that level. It's got stress on that level, the other level, from the other.
Okay, maybe it's the facet.
So all these are possibilities.
Okay. Yeah, nobody knows, but okay. So I'm going to go over a problem list. I want everybody to think about this because in 5-10 minutes, I'm going to ask you what surgery you want to do. So these are the problem lists that I feel in this patient. C6, C7, non-union with collapse. Axial neck pain, right upper extremity pain, the scapula, triceps, elbow. The screws have migrated anteriorly some. The C7 body is eroded. You have a long fusion mass. Can you get C6, C7 to fuse now? So the options. Do an anterior only, C6, C7 refusion ACDF using iliac crest. Maybe do an anterior only, take out the C7 body, so that you can get a large screw into T1 and do a corpectomy. Do this both anterior and posteriorly. Do you stage it? Do you do it in the same day? Which side do you do first, anterior first or posterior first? Do you need a foraminotomy in this patient because she has arm pain, just to wash out the nerve root and make sure there's nothing compressing it posteriorly? Posteriorly, do you put in a C7 pedicle screw? Do you do a lateral mass screw, or do you go down to T1? Do you use iliac crest? Front or back? Do you use allograft? What kind of device do you use? Do you use bone morphogenic protein? Do you do a cervical disc replacement? Can anybody add any other options? these are all the things that I thought of during this case. I wrote them all down. Okay, so I'm going to ask every surgeon at the end what they think they would do, but let me just go over just a couple of issues. So what implant do you use? So these are all the options: cortical composite, PEEK, just a metal implant, fibular allograft, and what are the risk benefits of all the different options? And then the middle is the horseshoe typical iliac crest bone graft. And then this is a non-union through a PEEK graft, and I feel it's difficult to diagnose a non-union with these implants because of quite often they throw off scatter, and you can't really see a non-union. And then how do you treat these non-unions? You take out the whole implant. I don't know what to do. And then like, how about if you have a non-union through one of these implants, and like in this case, how would you treat something like this? Now the screws have not migrated. It's a non-union. What do people in the room do for this kind of case? No migration of screws. Non-unions, symptomatic pain, exo pain. What would you do posteriorly? Would you use implants as well? Would you use lateral mass screws, no screws, a wire?
Yeah,
lateral mass screws. Is that what everybody does in this room?
I if there's no reason to go anterior, it's highly reproducible to go fusion posteriorly.
Yeah, much higher probability to have a posterior fusion.
Yeah.
And I usually go posterior. Nobody asks me what I do, but I'll tell you, I go posterior, but I don't put in implants if I think the screws are strong. I just pack iliac crest in a facet.
One note to the residents having to do with plate design. When you see a plate and someone says, "Look at this plate," it's a thinnest plate on the market. You always have to ask yourself, "Well, what are you giving up?" And because you can't, you're always you say yes to one thing, you're going to say no to something else. And usually, what you give up is your ability to angulate the proximal and distal screws, as we saw in the index films. They were appropriately angled up and down. But if you use that type of locking mechanism, you're not able to cover the entire plate. You're not able to cover the entire screw head, as opposed to what we oftentimes refer to as a manhole or a propeller type of locking mechanism. You put the screw in, and you have this propeller that you will turn, and you will visibly see it cover that screw. And that'll have a much better chance of preventing back out of that screw. So I get things put on my desk all the time about new devices, and some of them are just wafer thin. And you have to think to yourself, with whatever it is you end up doing, whether it's spine or joints or trauma or what have you, and someone shows you something that's almost too good to be true, you say, well, what are you giving up? And what I found is the thinner they get, the more difficult it is to angulate any screws, and the higher the likelihood is that you're going to have some screw back out.
Yeah, that's a good point.
So the other point is, if you are going to reconstruct it from the front, what type of plate are you going to use? And I would not use that same design.
Okay, so just non-union risks: metabolic smokers, infection, motion, which is our case, she's a non-smoker. Using allograft, the base of the construct, more likely to have a non-union. Patient has hip arthritis. Non-union risks for a 3-level, 82% fusion rate. So how do you make the diagnosis of a non-union? I usually use CT. You can see it on X-ray. Here are all the options for bone grafts. So everyone knows how to bones fuse: induction factors, osteogenesis cells, stability with a plate, and conduction is like a scaffold. So iliac crest is an option, allograft is an option. BMP.
For residents, quickly, what are the other ways that you can diagnose a pseudoarthrosis following UCD?
We have questions that you already presented in this case, but you can see gross movement between the spinal process of 6-7 reflections.
Okay, so you measure the spinal process distance. What else? What else can you look for? Another thing is screw convergence. There was that case from Italy that showed that you're going to put your screws in, say, parallel or a little bit divergent, and when you get post-op film, you'll see those screws begin to converge, and you have to worry about some graft absorption in the middle. So those are the things that you want to put in your note when you're dictating no evidence of screw convergence and graft subsidence.
So I thought about using BMP in this case because it's such a powerful way to get things to heal. So BMP came from Marshall Urist in was it 1965 he first started doing research, and Infuse came on the market in 2002 for A-lifts, and then for tibias in 2004. And I used BMP for years, actually, for a long time, and we noticed about, me and my partners, 3 cases of severe swelling where we put them in the ICU and we got worried and we stopped. And it was about 2 years after we noticed the problem, we stopped, that articles started coming out of swelling from anterior ACDFs, and it causes, you can see a tremendous amount of swelling in this case. You see it was a right approach. And the FDA put out a warning, it was 2008. By then, I think almost everybody knew not to use it in the front of the neck, and people weren't sure what to do when the warning came out. They were about 2 years too late. There was also an article in 2011 of a postoperative seroma causing neurological compression from a posterior approach in 2011. And this is actually a case of mine in 2011 where I used, it was a revision down to T1. I used BMP, and you can see the huge seroma post-op. And I treated this guy, I just cut the, you can see the seroma goes all the way to the skin. I just cut the skin to bedside, decompressed like a liter of fluid, and he was fine. But I have serious reservations about using BMP after all these. I had almost every complication there is with BMP, including one case of a woman ossified her psoas post-op. Because if you think about it, that's the psoas is right next to the transverse process. And I got a CAT scan, it was ossified. So posterior approach, yeah.
Spirit, how far post-op was this?
Post-op of day 8. So I was at the CSRS, I think, or we were talking about BMP, and I stood up and I asked the audience of 200 people, has anybody had any complications with posterior BMP use? Nobody said anything. So I was like, I'm going to start using it. And then I had this complication, and then I had another complication of bone growing into the foramen. So I was like, maybe I shouldn't be using it. This is a really powerful medicine. So, but do you want to use BMP in this case? So now, we did it for years, and we used 0.5 milligrams. We found that 0.5 milligrams did not cause the dysphagia problem. But I don't use it anymore. I think it's an option, but it's something you have to be very careful with, I think.
For a 4-level ACDF, which is relatively rare, it's something to consider, and you have to consent the patient.
Yeah. Okay, so any questions or comments? I'm going to keep going. So what's the etiology of the scapular and triceps pain in this patient? We're not sure. So C7 is usually the triceps. Neuroexam, you do a neuroexam. Dermatome scapula is T3, but I don't think that's it. This is what Paul was alluding to. This is a diagram of injecting normal facet. So you take normal people, put saline in the facet, put a whole bunch of it in there, and ask them, where does it hurt? And this is where the patients, the study patients, said it hurt after injecting their facets. So maybe it is her C6, C7 facet. Maybe that's symptomatic for some reason. I don't know. And then other things can masquerade. This is just a slide. Other things can masquerade as spine level. C5 is rotator cuff impingement. C6, C7 carpal tunnel syndrome, posterior interosseous nerve, cubital tunnel. You could have RSD, angina, thoracic outlet, and then other central problems can act like a spine problem. And then her exam, this is a shoulder exam. Her shoulder exam was totally normal. Her rotator cuff was intact. I just want to show you this. This is a case of a cervical non-union. This is an immediate post-op CT of a patient. I did it because she had a CSF leak. I wanted to make sure her trachea was not compressed. She was a very big woman. This is her post-op CT, post-op day 2. So what do you guys think of the fusion? The implants, everything look okay? Totally normal, right? Looks like it's going to go on the heel. But this is her 2 years later. You can see the lucent line that underneath the graft at C6, C7. So my question is, where do you think the pain's coming from at this non-union, and why was it so delayed? I have my own theories. Anybody any theories? So my theory is it takes a year or two for not to fuse, and it takes a year or two for pain fibers to grow into the old area. And I think the disc is richly innervated, like we know. So I think the pain fibers just regrow into this non-union area naturally because they were there in the first place. And then that's why patients have severe pain after non-unions, and it takes a long time because that's how long it takes to grow in. I mean, that's my personal theory. because they don't have pain for a long time. So then this is just a meta-analysis that's sent to everyone for revision fusions. Posteriors, fusion success is a lot higher, like 95%, than anteriors. Anteriors were not as high. But the clinical success, either you go anterior or posterior, is similar. So let's poll the audience. What would you guys, this is the same question, how would you approach this case and why? For the fusion, the surgeons. What do you think, Justin? What do you think? How would you approach it?
So, I mean, because those screws are a little bit proud, and it's annoying to look at the x-rays, and patients don't like to think they have loose screws, I probably would bite the bullet and go anterior first and remove the screws. And I probably wouldn't do anything more than that, because anything more than that's going to require taking the entire plate off, drilling out the bone graft, and then putting something new in place. And then I would flip same day and do posterior fusion with instrumentation over the same level she was previously used with lateral mass screws in the 7. And I leave the cervical thoracic junction out of it. To me, that's way more morbid, and then you're at the issue of them developing a nonunion at the cervical thoracic junction. She's locked up in that region. She doesn't have a slip there. She's got no stenosis there. I just can't see crossing that junction. You can buy a hole in the set of problems by doing that.
Okay, so remove the screws, and then C4 to C7 ACD, a posterior fusion. Wait, Paul, what are your thoughts? Do the foraminectomy or no?
Yeah.
Foraminectomy.
Just because she's got some
symptoms.
Unilateral symptoms.
C67 foraminectomy. Okay. What do you, Paul? How would you present?
Well, there's one article that you haven't discussed, which from one of our colleagues up north, Paul Mackley did published, where he compared redoing these anterior versus doing just posterior stabilization, found 100% fusion rate of the anterior non-union when you stabilize posteriorly. So I personally would consider doing a barium swallow to see if there's any impingement on the esophagus. If there isn't, I would just go posterior, put lateral mass screws at 6, 7, and use local bone. I wouldn't use BMP. And I think the literature would show that that's, 100% go on to then subsequently auto-fuse anterior, and you get the set's going to fuse posterior.
C6, so C posterior, C6, C7 fusion, instrumented.
And I would also consider a foraminectomy.
Instrumented only.
I would always instrument.
Instrumented, just posterior instrument.
Why wouldn't you instrument?
Iliac crest or allograft? Iliac crest or
I would
allograft?
use local bone. I would
Local bone.
Just take the spines process. You've got 3 spines processes, at least 2 spines processes you could remove that are already, you're going to expose them, take them off, and just use that and pack the sets at 6,
Okay.
7.
So just posterior. What do you think, Dr. Garai? How would you approach this case?
I would probably take that screw out from the front and do a posterior fusion.
C67 only?
Yeah.
Okay. How about Dr. Mohi? What do you think you should do?
Same thing, I think so. Take the screws out and really go posterior.
Posterior C67 only. Okay. So I thought about all. Yeah.
What did you do?
I'm gonna tell you.
Okay.
So I thought of all those options. The fear I had of going posterior only down to C7 is the lateral mass screw is weak at C7. It's a tiny lateral mass. And now I have this huge lever arm, and I'm counting on this weak C7 screw. So I was like, and then I don't want to put a pedicle screw at T1, at C7, because at C7, her pedicle, the vertebral artery is right next to her foramen. Pedicle, I meant to say. So I don't know if I should show you this, but you guys know this, but especially in her, just a second. She didn't have there on the left. You got to do a bullseye to get the pedicle in this case. And I've done the screws before, but I think why take risks? So I thought it's a long fusion mass. I want this thing to heal because I didn't want her to have a second surgery. So I thought this going just to C7 wasn't enough. And this woman wanted those screws out, no doubt. She was not going to. Patient wants the screws out. So.
But it depends on how you frame it, to the patient. And
she's a nurse. She wanted them out. She did research. She wanted them out. I mean, yeah, you could say that, but she was.
Super, but usually, if I mean, most people, if you explain the potential risks and complications and say, and prove with a barren swallow that there's no impingement on the esophagus, you know.
It should stop.
I think, sorry?
It should stop. The migration should stop.
Well, so it's going to stop. If you stop the motion, it's not going to continue to migrate. It's the motion that causes the migration of screws. So if you stabilize this posteriorly, you're not going to get any additional movement of that section that already has it's 2 years out now. It already has a thick scarred layer that's incorporating the position of the screw now. So.
Well, I think if you're not going to take up that screw, I would go 5 to 2 from the back.
Yeah.
I would go C5 to T2, just to make sure there's a solid fusion.
C5 to 2. Why would you do that if every other segment? I mean, if it's just the one level that's got
transitional segment, you know, if you fail to fuse and you have a loose screw in the front.
I mean, other options.
Right. I mean, those lateral masses don't look very healthy in that cast.
Yeah. I mean, the other options for you.
Seven was small. Lateral masses.
Well, the other thing you mentioned, there is technique to put in a spinous process screw. In 7, where you can go interlaminar screw at 7 if you're concerned. I can tell you that doing a lot of C7s, you usually get a pretty good screw, a deeper screw.
You got a long lever arm. You got a long lever arm in this case. It's not just a C6, 7.
Well, but it says you've got micro motion at one level. It's not a gross motion. I mean, if you do flexion extension, but it's really not. It's a long lever arm, but it's micro motion at that one segment.
Yeah,
so you can put a screw in. You can put,
I agree with you.
Screws.
I agree you can put screws there, though, but I think this is a special case because you have a long lever arm, and she's failed. So that's why I wanted to be sure this thing was going to heal. So I went down to T1. So I did a posterior T1, C5 to T1, did a framinotomy. You can see here what I did. These are my notes. I did first the anterior. I took the whole plate out, and then I put a graft at C7 T1. And then, believe it or not, there was a huge, like a 5mm defect where the non-union was. I debrided the whole thing out. I was like, oh, I got a hole now. So I put an allograft in there, and I put a new plate from C5 to T1. Then I flipped her posteriorly. The C5 to T1, I did a framinotomy there and fused it. And I used iliac crest because I wanted to be sure this thing was going to heal. And I think if you do an iliac crest right, I just cut the top of the bone, scoop out the middle part, reconstruct the allograft. Those patients don't have pain. And she didn't have any pain post-op after that. So then here's the CT, the lateral mass screws, pedicle screws, coronal reconstruction showing the bone. You can see there's a little graft here where I inserted it. And
so you put in something under the allograft that was already there?
Right. I debrided the non-union, and now I had this big hole.
Yeah.
So you can see it right here. This is the allograft, the new allograft, underneath the old allograft. And this is the C7 T1 ACDF. Here, you can see that's the new allograft. Here's the old allograft. Because I had a hole, I had to fill it with something. And this is her post-op. It's easier to see on the x-ray. So front first. Take it out, and then, and I don't know if front first, back first. I didn't think it mattered. Yeah. And this is her 2 weeks. She's like 6 weeks out now. Interestingly, post-op, scapular pain gone. So I think it was a radiculitis from non-union inflammation. I mean, who knows why. And I used the Medstar's not here, but I used the Medtronic plate, which for me, I mean, I think is better. And I took out everything in the middle because these things, I didn't want anything in the middle. There's a locking screw. I took it out. I didn't want there to be in motion, just in case. So my fear, the reason why I went to T1 is I felt C7 is very hard to instrument. You can't put a screw in the front. There's almost no bone there. And the back is weak unless you put a pedicle screw. So that's why I felt I had to go down to T1. I don't know. It made the surgery much bigger. But the whole case was, I was very worried about time. The whole case was, I think I finished at 3. So I started at 8:30 and I finished at 3. So it was quick. I mean, it's not technically, it wasn't too difficult. Okay.
Same day?
Yeah, same day. Mm-hmm. Yeah, I mean, it worked. I mean, Or maybe I was lucky, I don't know. But I mean, there's different, and I went back and forth. Every single thing that everybody said, I thought about.
Yeah, it'll be interesting to see what happens over the long haul.
Give us your follow-up. Give us your 2-year follow-up.
She's going to be absolutely fine until she dies.
How do you decide on T1 versus T2? I very rarely stop T1.
So what is your fear of I've had a fracture of T2 superior end plate. Is that what you're worried about?
Yeah, I'm worried about non-union T7, T1.
You think this is going non-union with both a front-back fusion, big anterior allograft in the front, instrumentation both sides, and posterior fusion?
Absolutely.
I don't think it's going to heal. I don't think it's going to be a non-union. I'm more worried that T2 fractures in like elderly women. I've had a couple of T2 fractures, and I think if I have a fear of osteoporosis, I go to T2.
But Justin, you would have instrumented posteriorly alone to T2, and I've done T1, 2 anterior. Do you think you would have just gone one level lower to T2?
My initial thought was to stop at C7, but if I was going to cross a cervical thoracic junction with a long lever arm already, then I would have gone to T2, no doubt. Yeah. You got a long lever arm, pedicle screws at 2-1. It's hanging on a lot right there. And it's not instrumented up to C4, which is the top of the construct. To me, this looks like a relatively short instrumentation for a really long lever arm. So I would have gone up to 4 and down to 2.
For about 10 years, Hopkins was doing the C2 to T2 construct for pretty much any posterior cervical decompression fusion, and now they're seeing big breakdowns of T2-3. Big lever. I mean, I don't know if there's a right answer, but
so you're saying it doesn't matter where you stop, it's going to break down anyway.
It doesn't matter where you stop, but I think the way those lateral masses look at C7, I would consider going at least to T1. But yeah, I'm in the mentality where if it's T1, then you go to T2. But then now we're seeing problems at T2-3. So I don't think there's a right answer. But I think going down to T1 was the right decision, and not stopping at
You're going to get burned either way.
Yeah.
I don't think there's an absolute answer for anything. You just have to consider all the risk benefits.
Exactly. I mean, the way you did it, I think you did, it was as conservative as you possibly could be with the crest bone graft, 2-level anterior, inner bodies, plus the posterior. Yeah. And when we looked at a biomechanical study with Brian in the lab, looking at essentially 3-column reconstructions like this. And there was a statistically significant difference in stiffness if you went to T2 versus T1. If you went to T3 versus T2, no difference. But you enhanced your stiffness significantly by adding a 1 level to 2.
For cervical thoracic junction fusions?
Exactly, C5, yeah. But look, you got good anterior.
What was the percentage improvement?
I'd have to go back and look at it.
Was it like 50% improvement or 10% or 5%?
For increased stiffness?
Yeah.
P-value was less than 0.5, 0.05.
So you feel after that study you should always go to T2 for stability?
If you're creating a sort of a 3-column instability.
Like a corpectomy or something.
Yeah.
This wasn't a corpectomy though. Yeah. I mean, this is not that unstable.
Right, exactly.
But I can see if I took out all of C7, the C7 corpectomy, then I think that makes more logical sense. It's not a big deal to do one more level, but you don't want to do it if you don't have to.
And the posture looks pretty good. She's standing here.
She's completely asymptomatic. She's doing great. I wouldn't show the case if she didn't do well. Right? No one shows bad cases. All right, I think
that's great.
Yeah. Any other questions or comments? No. Okay. Thanks for coming, everybody.
Good.
Thanks.
I was over at the Spine Center. I was over at the cafeteria. So just see if you have up here. Okay.